Now, the next is about the Jihvagata Vyadhi. Jihvagatastu Kantakaha Trividhaha Tribhirdoshihi Alasaha Upajihvika Jeti. There are 5 varieties of the diseases of the Jihva. That's Vata Pitta Kapala Kantaka as such. Now, Kantaka is when the surface of the tongue has been altered, and it could be of different varieties. According to Sushruta, Jihva Anilena Sputita Prasupta Bhavetya Shakachadana Prakasha. Shakachadana is these leaves of that tega, that teak wood like leaves, where the surface becomes rough. That's the polyps in the tongue, they become hypertrophied, that they are increased. Pittena pita parisvikhyate chita saraktehi apikantakaishta. Pittena, when there is a visheshan of the pitta, it produces burning sensation and there is a fragile, the bleeding tends to occur. The polyps become fragile over there. And kafena gurvi bahala chitacha mamsudgamehi shadmali kantakabhihi. With the kafaja variety, either it could be smooth surfaced, thick, tongue becomes rough and thick or smooth surfaced, or there could be projections which are something like the thorns of shalmali. So sharp projections could occur. So changes in the polyps of the tongue, they are suggestive of the dosha involvement, and the changes in the nature of the polyps in the tongue, they do occur due to either local factors like irritation, or could be even produced due to systemic factor. Many a times the systemic diseases can reflect on the tongue appearance. Now, from the current point of view, we usually identify these tongue abnormalities under many categories. Of course, there is one system called as a tongue diagnosis. Now, there is one system which says that any diseases of the system can be diagnosed with the tongue. But I don't attribute to that part of the issue. Of course, there are some people who follow that also. But from the practical clinical point of view, the shapes of the tongue and surface characters of the tongue seen, which could suggest of the diseases, are quite few. And among them, the most common varieties of the tongue surface abnormalities are either desquamate glossitis. Desquamate glossitis is a local factor which is often produced due to consumption of the irritant substances like tobacco and so on, or folded glossitis, where the tongue becomes folded. Like this is often a consequence of the systemic disorders like autoimmune disorders. Rheumatoid pathologies often can present with this kind of abnormality. And the candida glossitis, that's due to the candida inflammation, which again is suggestive of reduced immunity very often, and candidiasis we have discussed in many other contexts also. It's often suggestive of a reduced immunity. Could be any of those immunocompromised conditions. Then ulcerative glossitis is where there could be local multiple ulcers, which again is often a sign of systemic pathology, very often produced after consumption of antibiotics for a long duration, or often it also can occur due to the diseases like typhoid and so on, where the surface could become ulcerated. Or in case of or it's a phlegmonous glossitis, where the surface could become irregular, something like a pitta, where there would be a reddish lesions and there is a tendency for bleeding, some localized ulcers, which often is produced in herpes or as well as in chickenpox like viral infection conditions. Then rhomboid glossitis, where the middle area of the tongue having become inflamed, reddish, and the other surface surrounding area will be somewhat having phlegmons or something like this thick area. This is again common in case of typhoid-like conditions. So ulcerative or median rhomboid glossitis are often seen in case of the typhoid-like systemic diseases. Atrophic glossitis is often suggestive of a deficiency disorder. So these are the common varieties of the abnormalities of the tongue. Of course, there could be many more suggestive in some books but practically these are something which we can make out clinically and could be useful. And these are almost on the same lines as what Sushra has mentioned as the Vataja, Pittaja, Kafaja, Jihva, Kantaka. Then the next is Jihvatalaya Shvetu Pragadaha, so Alasa Sunyaha Kaparakta Murti, Jihvamsa Sambheti Pravurdho, Mule to Jihva Shamiti Pakam. The alasa is a condition where there would be a swelling which is at the base of the tongue and produced due to kapha and rakta. That's kapha and rakta means relatively painless initially, and later on it can have blood contained mixture like cystic swellings present there. Jihvansa stambhayati, when the size is bigger more, it affects the movement of the tongue, and it can even get infected. Now that's exactly the exact picture is seen in case of the ranula. Ranula is a variation of the dermoid, where some of these epithelial tissue cells, they get migrated to the lower plane and they produce a cystic swelling. It's characterized by cystic swelling. Initially it will be painless and surface will be smooth, transparent, and it may go on increasing size. Very often it may develop bleeding because during the movements of the tongue or the chewing of the food or so on, there will be bleeding, and that bleeding may suddenly increase the size. So many times the whole course of the ranula is initially there will be a painless small swelling below the surface of the tongue. Then all of a sudden it increases in size and then it may become painful. And sizes could be quite enormous. Many times the size could be enormous. And of course the only treatment as it has to be excised. And during the excision, the whole surface is easily separated. A simple incision over the mucosal surface allows the whole back to be excised as such. It's a very simple surgery, ranula surgery, and the whole cyst can be removed out because the surface of the ranula is quite thick and rigid. Now that's exactly the typical picture of the alasa mentioned by Sushruta, and the incidence of ranula also is not very rare, it's common. Then जिह्वाग्ररूप श्वेतुलिशि जिह्वाम् उन्नम्य जातः कफरक्तयोनिः प्रसेक कंडू परिदाहयुक्त प्रकथ्यते असौ उपजिह्विका चेति. Upajishvika is a situation where there would be a swelling over the tongue, either at the tip of the tongue or maybe at the base of the tongue, which is produced due to kapha and rakta, and it produces burning sensation or even later on suppuration. This is typical of what we call as a lingual abscess over the surface of the tongue. Now abscess over the surface of the tongue, unlike the abscesses elsewhere, elsewhere the abscess would be having a course like where there would be a soft swelling and then pus discharges, and you can see the pus purulent content in the tongue, because that is a movable area and it's coming into contact with the food regularly. There is always a spontaneous rupture, and that spontaneous rupture again results in further healing, and there is a tendency for fibrosis. You will always find a fibrotic mass, and the pus may not be constantly present. It will be painful. Patient may say that it's an ulcer, but when you look at it, it could be like there could be a painful localized indurated swelling, which may often produce confusion with the tumors of the tongue also. But you may see even the pustules in that area. So lingual abscess in the tongue is again a common entity which is considered as upajishvika. A similar situation also can be seen in actinomycosis. Actinomycosis is usually a widespread glossitis. The whole tongue would be inflamed and you will find deposition of that whitish material over the tongue usually. Occasionally it may also turn out to be presented like an abscess, but unlike that of the purulent abscess where you will find multiple pustules, in case of actinomycosis, the pustules number could be lesser and the size could be bigger, and because it is a deep-seated, the pus would be accumulated in the muscular layer in case of the actinomycosis. That's about the jihvagata vyadhi. The next is talugataha. Probably talu is equated to the palate, without differentiation of soft and hard palate. Now, anyway, the abnormalities of the talu are, it's not necessarily, the point is that it's not necessarily the palate. Now, when we say anatomically the palate, we limit to the soft and the hard palate, but according to Sushruta, the talu is the whole roof of the tongue, which includes a part of the pharyngeal part. Pharyngeal surface also can be included as a talu, because when Pandini says about the tala vyaksharas, there again you will have the similar issue. So it's not only the palate plus the walls of the pharynx also can be considered as a talu according to Sushruta. Now the diseases related to the talu are Garashundika, Tundikeri, Adhushaha, Kachapaha, Arbudam, Mamsasanghataha, Taluputaha, Talushoshaha, Talupakaha iti. Now among them the first is about the Kantishundi or Garashundi. श्लेष्मा असृभ्यां ताल्मूलात् प्रवृद्धो दीर्घः शोकः ज्ञातबस्तिप्रकाशः तृष्णाकाशश्वासकृतसम्प्रदिष्टो व्याधिः वैद्यैः कण्ठशुण्ढी इति नाम्ना. Kantashundi or Galashundi is the typical uvulaitis where the uvula becomes inflamed, where there would be a elongated dirghaha shopaha and bhatabasti prakasha, looks like a bulged bladder or some containing fluid containing bag like appearance is seen, and it produces kasashwasa, cough. Typical features of the uvulaitis are the same, like there would be a cough, irritated cough, non-productive cough, and very often the cough is produced when the patient lies down, and that's due to the physical irritation. See, that the uvula which is elongated, when it comes into contact with the surface of the pharynx, it produces irritation that results in the coughing reflex. But there would be no sputum, there would be no respiratory signs. When you auscultate, there would be no respiratory signs. That's the typical presentation of uvulitis, and the incidence of the uvulitis is now common. It has become quite common. Those who take a lot of ice creams and cold drinks, it's a very common entity, and the whole, it's almost a similar pathology like that of the tonsillitis. So uvula and tonsils, otherwise from the contemporary physiology point of view, they have a lot of similarity. Both of them have lymphatic tissues. Now anyway, so uvulitis is exactly the Galashundi or Kantashundi. Then the next is about adhrusha. Adhrusha is a शोकः स्थूलः तदुदाह प्रागुक्ताभ्यां तुण्डिकेरी मतातो शोकः स्तब्धः लोहितः तालुदेशे रक्ताग्नेय सोदृशोरुज्वराढ्यः तुण्डिकेरी and adhrita. These are similar conditions located at the same plane. The only difference is when the swelling presents with the acute inflammatory signs like toda daha prapaka, where there will be aching sensation and burning sensation or pus formation. That's considered as the tundikeri. When the same presents as a reddish swelling which is stabdha, which has become fibrous, hardened, and doesn't produce that acute symptoms of the pain and burning sensation, non-suppurative pathology, is adhrusha. Now these are exactly seen in case of the tonsillitis. Tonsillitis may present as acute tonsillitis, then you will have that fibrous or chronic tonsillitis, or even it can be peritonsillar abscess. An acute tonsillitis and peritonsillar abscess, it's typically seen with the shorter course, and there will be systemic symptoms of inflammation, local signs of inflammation. There could be pus seen over the surface, or there could be accumulated pus around the area outside the tonsils also. The difference between a tonsillitis and a peritonsillar abscess is in the peritonsillar abscess, the pus is accumulated around the tonsils, and the whole, it results in a shift of the uvula towards the opposite side. A tonsillitis may not result in a shift of the uvula. So deviated uvula is seen in case of chronic tonsillitis or peritonsillar abscess like conditions. Peritonsillar abscess like conditions. Whereas in case of acute tonsillitis, the uvula may not be shifted. So that's one of the basic differences which we make out clinically. Now these are considered as a tundikeri and adhrusha. So the clinical picture of these conditions is very typically described by Sushruta in these conditions. That's why I say, like, talu is not necessarily the palate. Talu involves the pharyngeal surface, tonsillar surface also. So it's totally the roof of the mouth, the whole surroundings of the mouth, other than the tongue. All that roof of the mouth is considered as a talu according to Sushruta. That's the difference between the anatomical nomenclature, the noun and anatomical nomenclature of Sushruta. Then the kachapa, kurmotsana avedano ashigra janma, then araktaha, that leading as such a fragile, ne kachapa shleshmanat syat, padmakaram talu madhye to shapum vidyat raktat arbudam proktalingam. Kachapa and the arbuda, talu arbuda, they again have a similar diseases. Like, the differences are when the lesion is presented as a hard, slow growing mass, that's considered as kachapa. When the similar lesion which is hard again, but it's presented with the fragile surface, bleeding, and looks like a lotus over the surface, padmakaram, looks like a lotus over the surface, that's considered as the arbuda, mams arbuda or talu arbuda. Now Tumors of the palate, again, they could be mainly of two categories, squamous cell carcinoma and adenocarcinoma. Squamous cell carcinomas are often produced as a result of the irritation, and they produce initially present as a localized hard mass. There will be initial dysplasia. The mucosal surface character will be altered. You will find that there will be some puckered appearance of the palate, and very often seen in the hard palate area. Not necessary that it should be in the hard palate alone. It tends to present with that puckered surface, a hard swelling, and then it goes on extending. That's exactly the picture of the kachapa, where it looks like the tortoise shell, the shell of the back of the tortoise. Whereas adenocarcinomas, they usually present with the ulcerative lesions and more commonly seen in the soft palate, and again not necessarily in soft palate, and they present with a fragile ulcerative swelling, and there could be bleeding. Course of the adenocarcinomas are usually rapid, short course. They tend to develop in a short duration and they tend to spread rapidly, whereas the squamous cell carcinoma is comparatively slow growing as such. That's the basic difference, and those differences are described by Sushruta as in the description of Kachapa and Raktarbuda. Then Dushtam Mamsam Shreshmana Nirujam Talantastam Mamsanghatam Ahu Niru Kusai Kolamatra Kapata Sap Mito Yukta Pupudah Taludeshe. Now, other soft swellings or smooth surface swellings of the oral cavity, and according to Sushruta, one is a painless and having a soft content is Mamsasanghata. When the same is painless swelling, similar swelling, which is having harder surfaces or harder content, kolamatra, looks like seeded, having some seed-like structure, and having medas-like, hard, relatively thick gelatinous substances, then that's considered as the puputa, then talu puputa. So talu puputa and mamsa sanghata, these are the two painless benign conditions. Now, a typical painless benign condition with a smooth surface and having a fluid content or having this somewhat soft content, that's Pansanghata, is seen in case of the follicular cysts. Cysts of the palate also are quite common now, and these present as soft bulgings, and very often these swellings could be quite big and then can even affect the speech. So that's how it's, and it's usually painless. Cysts of the these palate are usually painless. Whereas a dermoid in the palate, now we have spoken about the dermoid in some other context earlier. Dermoid is a sort of pathology where the embryonic tissue gets embedded in some other plane and then it divides. And often it can present with the ectopic tissues of different sorts like cartilages, bones, hairs, or some other gelatinous substances. Again, they are painless, and usually they would be presented at early age since birth often seen, and they may increase in size later on. And this kind of swellings, they are harder, and often they contain either gelatinous substances, many times hairs or cartilages also. That's because of the harder content. That's the talupuputa. So that's the exact description. Talupuputa and the follicular cyst, they are exactly described as Mamsasanghata and talupuputa as a Sushruta, as by Sushruta. Then Shoshotyartham Dirite Taluhu Shwaso Vata Talushoshaha Sapittat Pittam Kuryat Pakam Atyartha Ghoram Talunyenam Talupakam Mudanti. Talupaka and Talushosha. Now, talupaka is where there would be abscess, where typically it's a atyartha ghoram, pakam atyartha ghoram. There would be an abscess formation. As usual, anywhere the abscess now be attributed to the purulent conditions, suppurative pathologies, and it can present with that. Then talushosha, atrophy of the palate, of course, that may not be really a physical atrophy in the palate seen, but in the conditions where there is a neurological pathology, patients who have palsies of the cranial nerves, the palatine movements could be affected, particularly bulbar palsy patients. The palatine movement would be affected, and because of the palatine movement, the palate, the soft palate particularly, it looks like atrophy. It's whether there is a real atrophy or not is the question mark, but tone of the muscles there would be lesser, and hence it becomes atrophied and it becomes less functioning, flaccid, looks like flaccid, and probably Talishosha is related to that. So there may not be a visible or maybe a very strictly defined atrophy there, but visibly it may look like an atrophy because of the flaccidity due to the neurological conditions. You can see in many of the patients who have a bulbar palsy or any other neurological pathology where the palatine movement is affected, it can result in the similar issue. So I would be considering Talashosha as a neurological pathology of the palate where the palatine movement is reduced, or flaccid palate, flaccid soft palate. Whereas palatine abscess, of course, it's a, you can, as usual, any other abscess, you may see an abscess in the palatine area also, and it can be quite painful and usually the same course. The differentiation between a palatine abscess and the cyst and the dermoid is about the clinical course. In a typical palatine abscess, the course would have always that signs of inflammation like temperature being raised and the pain, even the collection of the pus, whereas cysts and dermoids, they would be painless. That's the difference. Then comes the kantagataha. Kantak is the surface of the oral cavity which is below the trachea or below the tonsillar level. So the vertical portion of the gut or gullet acid, the throat acid, that has to be considered as kantha, as well as the kantha also relates to the surface of the neck. So either surface of the neck as well as the lower portion of the lower pharynx area can be considered as a kantha. So we need to look at the anatomy from a different point of view. The anatomical nomenclature of the present day may not exactly fit into what's mentioned in Sushruta, but of course they are described same. The only thing is that the area-wise separation is not the same. Maybe whatever Sushruta has mentioned may be looking more practical. Like when you open the mouth and when you see the contents easily, that's the talu. When you need to bend the neck and then look in a deeper level, then becomes the kantha, or something where the location is vertical. That could be the kantha and the gala. The surface of the neck also is the kantha. So that's how it's looked at. Whereas now we nomenclate based upon the tissue factors, the functions and so on, the other anatomical details. So this doesn't make a huge difference, but this has to be understood as it. Now among the Kantagata Roga, the diseases are Pancharohinya. There are 5 varieties of the Rohinis. Kantashalukam, Adihvaha, Balayaha, Balasaha, Ekavrundaha, Vrundaha, Shatagni, Gilayu, Galavidrili, Galovha, Swaragno, Mansatanaha, Bidari Cheti. Balaya or Valaya, these are the same. Ba and Va, they do not have a difference in the pronunciation. Then the Rohinis are those where there is a proliferation of the tissue in the tongue. And proliferation of the tissue in the tongue with the acute conditions is typically seen in case of the diphtheria. Diphtheria conditions are now less frequent. Rather, since past 20 years in India, diphtheria is not reported. So chances of having seen a case of diphtheria is virtually not possible. So all that we have to depend upon the recorded clinical issues. So diphtheria is supposed to be eradicated from India due to the immunization schedules. So anyway, whereas earlier it was more common, and we have that historical facts like many deaths due to the diphtheria. Diphtheria is considered to be a very potent fatal condition. Now anyway, the whatever Sushruta has mentioned is that is a typical proliferation of the tissue in the neck, which could be presented in different fashions. And when Gale Anilaha, Pitta Kapote Muchida, Pratak Samastasha, Tatheva Shonitam, produce mamsam Galalodhino Ankurana, which produces a ankura or a tissue, a pseudo tissue, pulse membrane, which can produce the obstruction to the respiratory tract, Galarodhinaha Ankurana. So Asuhara, Sa Asuhara, it's a fatal condition that's called as Rohini. So it's exactly the description of the diphtheria. Now, depending upon the pattern of the distribution, they are named as Bhataja, Pittaja, Kapaja. When Jihvam Samanta, the Brishavedanaya, Mamsankura, Kanta Nirodhinasyuhu, तां रोहिणीं वातकृतां वदन्ति वातात्मक उपद्रवप्रगाढयुक्तं. Now, when the lesions proliferate from surrounding the tongue area, surrounding the tongue, and then they produce the obstruction, and they have the Vataja Lakshanas, that's considered as Vataja Rohini. Whereas a rapid developing Kshiproktama, Kshipra Vidahpaka, Tivradvara, Pitta Nimittaja Syata, Sroto Nirodhinyapi Mandapaka, Gurvi Sirasa, Kapasambhava Vai. When it is rapidly spreading and there is more clinical signs of inflammation and more fragile tissue, that's considered as a Pittaja. A relatively Mandapaka, relatively slow growing, that's considered as the Kapaja. Gambhira Paka, Apratibara Vidya, Doshalinga, Trasambhavatu, Spotatika, Pitta Samanalinga, Asadhya Pradishta, Rudiratmaka Yam. Raktaja variety also would have a similar feature of that of the Pittaja variety. Then when the Paka, the separation is quite deep seated, that's considered as the Dvidosha. So whether these kinds of differentials can be made out or not in a case of diphtheria, I don't know, because I have not seen a case of diphtheria. So all that is from the sources, some even internet sources, the collection of photos, where there would be a membrane-like proliferation, pseudomembrane, and that pseudomembrane may even result in a bulging in the neck. That's the typical presentation of the diphtheria. And of course, we will come to the other part. Other part is now suppose a patient of your chances of seeing a case of diphtheria is lesser, but as based upon the theory part, like suppose a patient of diphtheria comes in, the primary treatment is ensure that the patient's respiratory tract is maintained intact by tracheostomy, make the opening in the trachea and ensure that the air enters in. Do not handle the membrane. These membranes, though produce the obstruction, they are not supposed to be handled because the handling of that would increase the toxicity. But of course, Sushruta has considered Rohini as a Lekhya Vyadhi, that curating was considered as a treatment by Sushruta. So I will not go into that controversy now. We will leave that now as we discuss maybe in due course of time when we go into the Chikitsa. Then कोलस्थिमात्रः कफसम्भवयो ग्रन्थिः गले कण्टकशूकभूतः खरः स्थिरः शस्त्रनिपातसाध्यः तं कण्ठशालूकम् इति ब्रुवन्ति. Now this is again typically a dermoid cyst where there would be cholasthematrah, hard and nodular swelling, which is painless and it's always surgical. There is no question of medical treatment. That condition is what Sushruta has a kantha. Now all those shalukas which are mentioned, they are typically of the dermoid cysts, and we have discussed about the dermoid and some areas of the dermoid in the oral area in the earlier some other sessions. Like now, pharynx also is one of the area where the dermoid is quite common, and it's typically presented as a firm, painless swelling which may increase in size, and often clinically this produces a confusion with the thyroglossal cyst because it's in the midline. It often produces a confusion with the thyroglossal cyst, and the primary difference in the clinical situation between a thyroglossal cyst and the dermoids are thyroglossal cyst moves upwards during the deglutition, whereas the dermoids of the neck either they move downwards during the deglutition or they may not be moving during the deglutition. If they are superficial, they may not move with the deglutition. If they are connected to the pharyngeal muscles, they move downwards, whereas thyroglossal cyst moves upwards during the deglutition. That's how you can differentiate between a thyroglossal cyst and the dermoids of the neck. Anyway, that's one of the issues. Then the next part is about the Jivhagrarupa Shvetukkapatu Jihva Prabandhopari Raktamishata Neyo Adijihvaha Kalu Roga Yeshaha Vivarjayet Agata Pakamenam. It's a swelling of the posterior aspect of the tongue, and it may look like a projection from the surface area. That's exactly the epiglottis, and a inflammatory pathology of epiglottis or epiglottitis is adhijihva. Adhijihva is where the lesion is presented over the jihva prabandha at the base of the tongue, and it's projected from the surface of the tongue. It's the typical feature. Of course, epiglottitis is one of the part of the upper respiratory tract infection. Many of the patients who have upper respiratory tract infection may also have epiglottitis, and that epiglottitis may produce a dyspnea, difficulty in breathing, and stridor, sounds produced during the breathing is a typical feature of the epiglottitis. And of course, it can be seen easily when you open the mouth and look at it, a normal epiglottis and a epiglottitis which has become inflamed. Or if you do a CT scan, there could be signs of the pus collected, the fluid collected also in the epiglottis could be seen as such. Then बलास एव आयतम् उन्नतं तु शोभं करोति अन्नगतिं निवार्य तं सर्वथैव अप्रतिवारबीजं विवर्जनीयं बलयं वदन्ति. Then गले तु शोभं कुरुत प्रबुद्धो श्लेष्मानिलो श्वासरजोपपन्नं मर्मच्छिदं दुस्तरमेतदाहुः बलाससंज्ञं निपुणाः विकारम्. Balasa and Balaya are the conditions where there would be obstruction to the pharynx. The differences are Balasa presents with elevated swelling and usually what we call as a pedunculated swelling, a swelling which can be felt as a pedunculated swelling, whereas Balaya is Balasa is where there would be pedunculated swelling, whereas Balaya is a circular swelling, annular swelling which surrounds the whole pharynx wall. Now, these are the typical presentations of the pharyngeal carcinoma of pharynx or carcinoma of the GIT as a whole can present with the various clinical presentation. Among them, annular, the circular lesions, they produce the obstruction more frequently, whereas a pedunculated obstruction, they produce obstruction relatively later, but otherwise they are similar. So, from the basic clinical point of view, difference between annular and the pedunculated swellings are only that much. But histopathologically as well as from the point of view of this course of the disease, annular would have a early obstruction symptom, whereas the growths otherwise non-annular or pedunculated growths would have relatively later obstruction symptoms, and these are typically described by Sushila as Balasa and Balaya. So I would be generalizing this as a pharyngeal obstructive pathologies, and which are often asadia conditions, that's why the tumor pathologies as such. Then another condition again where it can be producing the obstruction through the food passage, maybe below the level of the pharynx, which may not be seen directly to the naked eye, if you need an endoscope, would be the Ekabranda and Brunda. Vruktonato yashvetutsadahah kandanvito apaki amruduhu kuruscha नामना एकवृंद परिकीर्तितोसौ व्याधि बलासक क्षतज प्रसूतः, a kappa raktaja vyadhi which is again presented as a circular swelling and produces non-suppurative swelling which again produces the obstruction to the passage of the food. That's either considered as ekavrinda, whereas the same ekavrinda similar condition which is presented with the inflammatory sites like Tivrajwaram Vrundam Udaharanti, Samunnatam Mruttam Amandadaham, Tivrajwaram Vrundam Udaharanti, Tancha Pitta Kshatrya Prakopat Vidyat Satodam Pavanasrajam to. So that's again exactly the typical features which you see in case of the esophageal obstructive pathologies. Among the esophageal obstructive or pharyngo-esophageal junction, one of the conditions which can produce obstruction is the diverticulae. Diverticulae in the pharyngo-esophageal junction are quite common, where there would be an extra bulging scope, and usually it's painless. Initially it's painless, and it may later on become painful when it's inflamed. So diverticulosis and diverticulitis, these are the two conditions. Of course, diverticulae are common in the whole GIT anywhere. Any lumen which has a extra projection over the area is a diverticulum. And in the pharyngo-esophageal junction, the diverticulae are common, and these diverticulae, they present as soft bulgings. You can see these projections over the area, soft bulging bag-like projections. As long as it doesn't contain the food or it doesn't get accumulated in the food, it may not produce any symptom. When the food gets in, it may produce a bulging. So recurrent swellings, bulgings could be the common symptom. And when there is a stagnation of the food and which results in the inflammation, then you will have the painful conditions. And that's exactly what's mentioned by Sushruta as Eka Vrunda and Vrunda, depending upon the course. When there is more of inflammatory pathology and results in diverticulitis, it's the Vrunda. And Eka Vrunda is the other way. Even these are the conditions which can produce obstruction to the passage of the food. When the patient swallows, there would be dysphagia, but typically that dysphagia would be this inconsistent dysphagia. At times there could be dysphagia, at times there may not be. The dysphagia, when the diverticulum is filled, there will be dysphagia. If the diverticulum is emptied, there will be no dysphagia as such. Then वर्तिर्गना कंठ निरोधिनीयाचिता अतिमात्रं पिशिर प्रोरोहि नाना रुज उत्साहकरी त्रिदोषाज्ञेया शतग्नि व शतग्नि असाध्या. Shatagni is where there would be multiple swellings which look like wick vartirgana, ghana varti, like wick-like appearance. That's small thin projections over the area, and they may produce an obstruction to the neck as such. And these are typically seen in case of the polyps. Polyps in the pharynx. Again, polyposis is another of the systemic disease where there could be polyps present throughout the GIT or any of the areas. It's considered as often maybe a pre-malignant condition or possible early malignancy conditions also, where there will be finger-like projections anywhere in the gastrointestinal tract, and in the pharynx also the same can occur. And when it occurs in the pharyngeal area, Sushruta has considered them as a shatagni, which can produce the obstruction. And usually polyps in the pharyngeal area may not produce a total obstruction, but irritation in the throat, continuous irritation in throat, and they can be a cause for that irritant cough, pharynx, or the maybe nausea, vomiting also could occur due to the pharyngeal polyps. So that's about the other thing. Then ग्रंथिर्गले तो आमलकास्थिमात्रः स्थिरो अल्परुकुस्यात् कफरक्तमूर्तिः संलक्ष्यते सक्तमेव अशनं तं च शस्त्रसाध्यस्तु गिलायुसंज्ञः. Gilayu is a swelling which is seen in the gala area. Gala is the external surface of the neck, and it is usually hard. Amalkastimatra, hard in consistency. Alparuku, painless. That condition is often seen in what we call as the cold access, lymph nodes enlarged, or occasionally it also can in case of the salivary gland swellings, particularly myxomas of the salivary gland also can present with the same. So clinically, a patient presenting with a firm swelling, painless in the area, in the submandibular area, either it could be a tubercular, or it could be a myxoma, or even it could be due to the secondaries, Warshaw's phenomena. Secondaries from either the tumors of the oral cavity or tumors from the GIT anywhere, it can occur. So depending upon the locations, you will have to make out further. So of course, in case of Warshaw's, it is supraclavicular, where you will be location at the lower level. The other differences from the clinical point of view in case of the salivary gland or parotid gland pathologies and the neck glands are, in a parotid pathology, the fossa between the neck, the ear and the mandible would be filled up, whereas in case of the lymph node swellings, this would be blank as such, flat or dipped as such. As you see in this image, the fossa is not filled up, so actually it looks like a lymph node swelling. If there would be parotid swelling, the swelling, you will not be able to insinuate your finger between the mandible and the mastoid process as such. So this area, this angle will be filled up in case of the parotid swelling. That's how we make out that difference clinically. And of course, then it needs all that course of investigations like scanning to confirm, and then the planning and management. Then sarvam galam vyapya samuktito yashofo rujo yatra santi sarvaha sa sarvodosho galavidhradistu tasyaiva tulyah khalu sarvajasya. Retropharyngeal abscess is the other condition. Galavidhradi is obviously the abscess. Now, primarily, when the patient presents with the retropharyngeal abscess, and it has to be differentiated from a peritonsillar abscess. Retropharyngeal abscess is seen in the midline and presented with bulging in the midline, whereas peritonsillar abscess would be seen in the bulging at the sides, and the midline would be depressed. And this is quite important to make out them, because when you plan for the drainage, the plane of the retropharyngeal abscess is much below, and it may even reach up to the spines, whereas peritonsillar abscess is superficial. So this differentiation is important from the clinical point of view, and it also can present with the spasm of the neck muscles. Retropharyngeal abscess is even presented with the spasm of the neck muscles, and torticollis-like defects could occur. Patient may not be able to extend the tongue, extend the neck, That's the typical of the Galavidhradi, retropharyngeal abscess is the other condition. Then शोफो महान अन्न जलावरोधी तीव्र ज्वरो वातकतेः निहंता कफेन जातो रुधिरान्वितेन गले गलोघ परिकीर्त्यसो यो अतिप्रताम्यत श्वसिते प्रसक्तं भिन्नस्वरः शुष्क विमुक्तकण्ठः कफ उपदिग्धेषु अनिलायनेषु सरोग्ने स्वरघ्नः. Swaragna is another of the condition where, and galogha, these are the two conditions where there would be obstruction to the passage of food as well as the obstruction to the respiratory tract. Now in galogha it's annajala avarodhi, where there is an obstruction to the passage of the food, whereas in case of the swaragna it's a difficulty in breathing, the hoarseness of the voice. Shwasiti prasaktam bhinnaswaraha. So that obstruction to the larynx and obstruction to the pharynx. These are the two issues which are mentioned by Sushruta as the galogha and the swaragna. Now, when from the clinical point of view, a similar clinical presentation can occur in case of the anaphylaxis conditions. Anaphylaxis often presents in the laryngeal edema or pharyngeal edema. A patient of anaphylaxis, allergic reaction, all of a sudden can develop that, and these particularly laryngeal edema, and of course in these conditions pharynx and larynx both would be involved, and you may have patients with the difficulty for swallowing as well as the respiratory difficulties. And respiratory difficulties, obstruction to the respiratory passage is more critical because it can result in immediate death, whereas a pharyngeal obstruction you still have sufficient time to manage the patients. So usually we give more importance to the laryngeal edema than the pharyngeal edema. Of course, Sushruta has categorized them into two categories, whereas in anaphylaxis both are important, but both are seen, but primary importance is given to the laryngeal edema because of the acute course. And of course, in a patient of anaphylaxis, patient presents with the anaphylaxis, the first of the thing which you have to see is whether there is a laryngeal edema or not, and the degree of laryngeal edema. If the degree of laryngeal edema is more than the 50% or grade 2, then it cannot be managed only with the medical treatment, you need tracheostomy. So that's one of the important criteria. A patient presenting with anaphylaxis, you decide whether the patient needs tracheostomy or not immediately within short period, because delay there can be fatal. If the laryngeal edema is beyond 50% or grade 3, then tracheostomy is a must. Whereas if it is in the earlier stage, tracheostomy could be avoided. You may try with the other treatment like glucocorticoids and so on. So that's one of the important issue when you deal with the patient of anaphylaxis. Maybe now Sushruta has not given that kind of a categorization. Sushruta has given the categorization as a patient presenting with the difficulty in swallowing of the food, difficulty in the breathing. Maybe from the clinical point of view, symptom point of view, the first 2 degree patients, it's mainly that swallowing difficulty which is a major concern for the patient, because the obstruction to the trachea is comparatively lesser, whereas the next 2 degree patients, these respiratory difficulties are more critical than the other way, and probably that has resulted in that differentiation between galogha and swaragna as 2 different conditions. Then प्रधानमाने श्वेतुत्सुकस्थो गलोपरोधं कुरुते क्रमेण समांसदानः कुरुते कथितो अवलंबी प्राणप्रणोतो सर्वकृतो विकारः. Another of the sarvaja vikara is a mansatana, a fleshy swelling seen in the gala, that's in the neck area, often the tracheal area. The tumors of the trachea are vocal cords. These are the ones which can produce galoparadha. They can produce the obstruction to the passage of the air and shwetu, neck as such, and pranapranoto can be fatal. Now that's also absolutely true. Tumors and swellings of the vocal cords and larynx, they can be presented as the mamsakana. That's one of the issues. Then sadahadodam shwetum saraktam antargale puti vishirna mamsam vittena vidyat bodhane vidayim parshve vishayarshayat satu ena shete sarvaja vyadi, where there would be shwayatu, swelling, which is having maybe fragile surface, and even puti vishirna mamsam, there would be even the destruction of the tissue. That's the typical features which are mentioned in case of the pittaja sarvaja vyadi, sarvasara vyadi. This is exactly what we call as mucositis, often produced due to irritant substances, or often it can be seen in pemphigus. The whole mucosa of the oral mucosa it becomes inflamed, and then there will be a lot of hemorrhagic spots. This kind of picture is very frequently seen in pemphigus vulgaris. Patients of pemphigus, this is quite common, or it can also occur due to the irritation with the irritant substances. That's about the disease. Then sarvasarastu vata pitta kapha shonita nimittaha. Sarvasara vyadhi, they are produced due to vata pittaja kaphaja vyadhis. And these again can be categorized as a स्फोटैः सदा सतोदैः वदनं समन्ताद् यस्य आसितं सर्वसरस्वातात् रक्तैः सदा हि तनुभिः सपीतैः यस्याचितं चापि सपित्तगोपात् खण्डयुतैः अल्परुजैः सवर्णैः यस्य आचितं चापि सवैकफेन रक्तेन पित्तोदित एव कश्चित् प्रदिष्टः मुखपाकसंज्ञः. Mukhapaka are the sarvasara vyadhi, another category. Of course, mucositis also may be categorized as sarvasara, though Sushruta has not mentioned them as a sarvasara. Whereas the eruptions in the oral cavity can present with either a scattered multiple eruptions. Spoteihi, sasaudehi, vadanam samantat, yasya achitam sarvasara vatat. In a typical vataja variety, you will have a scattered eruptions seen, and that's typically seen in what we call as the chicken pox like conditions. And then when there will be more of burning sensation and yellowish fluid containing swellings, that's typically seen in case of the other viral infection conditions, HSV virus like conditions, or even it can be seen in HIV like conditions. When the similar condition will be presented with the multiple whitish depositions and the tissues, damage to the tissue, that's typically seen in the candidiasis, kaphaja variety, or could be others. So in total, it's about the different mucositis. Now from the present point of view, we consider this as different mucositis. Mucositis typically produced in the pemphigus as we seen in the earlier picture, or mucositis with the eruption seen in the diseases like chickenpox, HIV, candidiasis, they all can be considered as diseases. With this, we conclude iti Sushrutamithasthane, Nidhanasthane, Mukharoga Nidhanam Nama, Shadaswadhyaya, and the Nidhanasthana is completed. So we will wind up today. If there are any questions, I will try to answer, and then there are a few questions. How can we differentiate follicular tonsillitis from diphtheria? So as such, diphtheria is less common. So chances of making a diagnosis of diphtheria now is virtually not there. But in as per the theory, diphtheria patients would have a rapid course, and there could be muscular lesions. The toxemia produces the flacidity of the muscles. Respiratory difficulty would be more severe in case of the diphtheria. As far as clinical experience is concerned, I have not, as I told you earlier, I have not seen a case of diphtheria till now, because as per our document, since 15 years, the diphtheria is not reported in India at all. So about diphtheria, it's only the theory. Then what's the difference between Gilayu and Panasika or Pashana Gardhava? See, Pashana Gardhava is seen on the surface, it's Exudaroga, and more of myxoma. And Panasika also is a localized tumor which can be presented anywhere. See, when we say Panasika, it's often in the Exudaroga, it's mentioned that the location is not specified. But when a similar lesion is seen in the gala, it's a Gilayu. So it depending upon the location, you say that names as such. That's it. Then another question is, if you consider inflammation to be a resultant of prakupta pitta, then Shula should be seen in Pittaja rather than Vataja. See, pain or Shula can be produced as a result of inflammation. Pain also can be produced due to the irritation of the nerve endings. When the irritation of the nerve endings produces the pain, Shula, that's Vataja. When the pain is produced due to the inflammatory products producing the same, then it's the Pittaja. So that's how we have to make out like. Then in Sarvasara Roga, Vataja says spota utpatti. There would be eruptions. That's exactly what you see in case of the chicken pox like. Spota. Oh, okay. Now, see, that's in case of this Vataja Sarvasara Roga, spota are mentioned, not the Shula. That's your question. Okay, that's not a rule. See, it's not a rule that every time there would be the Shula as such. Even maybe though not very valid description, in case of the involvement of the nerves, in case of the herpes, there would be eruptions. Then really the other way, pain of course would be there, because of the involvement of the nerve endings. So eruptions in case of a neurological conditions is possible, which I give you an example as a herpes, but that's not a very objective description. That suppose you have this notion that water should be related to the nerves, which I do not agree. So I do not say that that's a very valid statement, but still for those who have a feeling like water should be always attributed to nerves, and eruptions in that. So in case of the herpes, eruptions are the features there, and even in case of the chicken pox, it's about the inflammation of the nerve endings which produces the same. I think that's a moderate answer, not a very satisfying answer there. Okay, that's about 3 questions and answer. So we will wind up now. Thank you.